Welcome to this explainer. Today, we're taking on the NICU ventilator. Now, to an outsider, this machine looks incredibly intimidating, right? It's just covered in numbers, alarms, and blinking lights. But today, we're going to transform that complex piece of equipment into a totally understandable dashboard of life support. We'll break down exactly what these settings mean and, most importantly, how to read the baby's physical cues to get them dialed in just right. Here's our roadmap for today. We'll start with a look at the overall dashboard, then dive into PIP, PEEP, setting the breathing rate, dialing in timing and oxygen, and finally, how to troubleshoot when a baby fights the machine. Let's get right into it. Section 1. The ventilator dashboard, specifically looking at the Draeger BabyLog 8000. So looking at the big picture, when we stare at one of these interfaces, we're really just looking at the control panel for a massive feedback loop. We are constantly adjusting what we tell the machine to do based strictly on how the baby responds. It's this ongoing dynamic conversation between the technology and the patient. Moving on to Section 2, PIP, or Peak Inspiratory Pressure. This is all about finding the right push, and it's frankly one of the most fundamental settings you'll interact with. So what exactly is PIP? Think of it as the peak push of air that the ventilator delivers into those tiny newborn lungs during each and every breath. It's the maximum pressure in a respiratory cycle. But how do we know if we've set this pressure correctly for lungs that are so fragile? Well, to get this right, we use the rule of 3. First up, look at the baby. You want to get right down to eye level with their chest. The rise should be just visible, nothing crazy. Second, check the numbers. We're aiming for a tidal volume of about 4 to 6 milliliters per kilo. And third, check the oxygenation, or SpO2. If the chest is rising gently and your volumes are in that sweet spot, you've nailed the PIP. It's pretty obvious when you're off target. If your PIP is cranked too high, you're going to see an exaggerated chest rise and a huge tidal volume. That's your cue to dial it back. On the flip side, if the chest isn't moving at all and volumes are low, you're just not giving enough support. Seriously, your own eyes are your absolute best clinical tool here. All right, Section 3, PEEP. This is all about keeping those lungs open and maintaining that crucial baseline pressure. PEEP stands for positive end expiratory pressure. People get this mixed up a lot, but it's simply the continuous pressure holding the lungs open after the baby exhales. Imagine a tiny balloon. We usually set PEEP around 5, just to keep that lung balloon from completely deflating and collapsing between breaths. Just like with PIP, we've got a rule of 3 to make sure our PEEP is on point. Clinically, you're watching the ribs for any intercostal retractions. Radiologically, you want to see about 6 to 8 rib spaces of expansion on an X-ray. And then there's the blood gas and SpO2. PEEP is a massive player in driving your mean airway pressure, which directly dictates how well we're oxygenating the baby. It's a really delicate balance. If you're seeing rib retractions or an X-ray showing only 5 or 6 spaces, those lungs are collapsing. You need a bit more PEEP to stent them open. But if the chest looks totally hyperinflated and barrel-like, you've gone too far and you need to back it down. Now here's where the math comes in. Delta P. This is simply your PIP minus your PIP. If you drop the P but keep your PIP exactly where it is, your delta P actually goes up. This gives you a bigger tidal volume, which makes delta P your absolute best friend for washing trapped carbon dioxide right out of the baby's system. Section 4. Setting the breathing rate. Here, we're matching the machine to the actual pathology the baby is facing. As you can see, your target rate isn't a one-size-fits-all kind of deal. If you've got a term baby, say with meconium aspiration syndrome, you're generally starting around 40 to 45 breaths a minute. But a preterm baby fighting RDS, their lungs need a faster rhythm, usually starting closer to 50 or 60 breaths a minute. You always treat the underlying disease, not just plug in a standard number. So why do we tweak the rate? Because it directly controls the minute volume, which is just tidal volume times the rate. If your blood gas comes back with high PCO2, bumping up that breathing rate increases the total minute volume. Basically, you're increasing the turnover of air to wash out that stubborn carbon dioxide. Okay, Section 5, timing and oxygen levels. We're talking I time, E time, and FiO2. Getting the pressures right is one thing, but timing the breaths perfectly is a whole other ballgame. Inspiratory time, or I time, is just how long the machine actively pushes air in. For a tiny preterm baby, we keep this short, around 0.33 to 0.36 seconds, whereas term babies can handle up to 0.4 seconds. Then there's the I to E ratio, the time spent breathing in versus breathing out. Usually that sits at 1 to 2, but if a baby's holding on to CO2, we might push that to 1 to 2.5 or even 1 to 3 to give them extra time to exhale. Now, a golden rule for oxygen, or FiO2. keep it to the absolute minimum. If a baby is satting beautifully at 95% on room air, so 21%, that is fantastic. For preterm babies, we have to be super strict, keeping their SpO2 strictly between 90 and 94%. If they creep above 94, no questions asked. You've got to turn that oxygen down. To make all this happen, the pressures, the volumes, the timing, the machine needs an engine, and that's your baseline inspiratory flow. We usually set this between 6 and 8 liters per minute. If you ever find yourself needing to deliver way higher pip pressures, you're going to have to turn up this flow to give the machine the actual power to do it. Finally, Section 6, Troubleshooting Ventilator Asynchrony. This is what happens when the baby starts fighting the machine. It's honestly one of the highest stress moments on the ward, right? A baby who is perfectly comfortable suddenly starts retracting and fighting the vent. The knee-jerk reaction might be to just reach for a sedative. But hold on, we need to act as detectives here. Why are they fighting? If you just sedate them without looking for the why, you risk causing their entire respiratory effort to completely collapse. So here's your troubleshooting checklist. First, check the tube. Is it blocked? Because if it is, the baby literally cannot breathe. Next, are your pressures high enough, or is your set rate too low for what their lungs are going through? Also, watch out for metabolic acidosis or shock causing them to hyperventilate to compensate. Or it could even be neurological, like encephalopathy causing erratic breathing. Bottom line, find the root cause and fix it. This really changes how we look at the whole dashboard. True respiratory support isn't about bullying the baby's lungs into submission with our settings. It's about listening to the baby's physiology and adjusting the machine to give them exactly the support they're asking for in that moment. Our resource material really hits the nail on the head here. Treat the cause, not just the symptom. You should never jump to sedation when the real answer is probably sitting right there on the dashboard in front of you. Tweak your PIP, adjust your PEEP, change your rate. Fix the underlying problem. Don't just mask it. Well, we've pretty much demystified the NICU dashboard today. But remember, this highly advanced piece of technology is really only as smart as the clinician reading the baby's cues. So I'll leave you with this. The next time that ventilator alarm goes off, what's the very first piece of feedback you're going to trust to solve the puzzle? Thanks for tuning into this explainer, and keep a close eye on those clinical signs.